Hello everyone, this is my presentation on dissociative identity disorder. So, dissociative identity disorder is regarded as the most severe out of four main categories of DDs or dissociative disorders found in the DSM 5. There's dissociative identity disorder, depersonalization, derealization, and dissociative amnesia. Um, It's thought of as a post traumatic developmental disorder in which a client experiences disruptions in identity. When they first seek treatment, they typically have a host identity who identifies with the actual name of the client and 2 to 4 alters or dissociative states, also suffering from memory issues. So, dissociation is a natural defense mechanism in humans. Disconnecting from thoughts, feelings, memories, behaviors, physical sensations, or sense of identity can briefly shield someone facing a state of overwhelm. And some people have more of a biological predisposition for that than others. Um, it is common for clients with DID to have a history of both severe and chronic childhood abuse, both physical or sexual, committed by an attachment figure. Typically, the earlier and more severe the abuse was, the greater the risk of developing DID. So, DID is diagnosed by recognizing its core features. They are disruption of identity. The client must display 2 or more distinct personality states. Discontinuity in the sense of self and agency. So, the client has noticeable shifts in affect, behavior, consciousness, memory, perception, cognition, or sensory motor functioning. And amnesia. The client experiences recurrent gaps or holes in recalling everyday events, traumatic childhood events, or crucial personal information. It's commonly undiagnosed because of a lack of structured diagnostic interviews that are tailored to catch dissociative symptoms. It also has frequent comorbidity with mood and personality disorders, and it has a similar symptomology to psychotic disorders. So, for an accurate diagnosis, be sure to use the structured clinical interview for DSM 5 dissociative disorders when screening. Its prevalence ranges broadly. You'll see numbers from 0.4 to 14%. There's a big debate among psychologists around the validity of the disorder. Um, so it really differs due to clinical settings, cultural differences, methodology, and of course, a lack of consistent diagnostic tools. It's more likely on the lower percentage. However, the number actually changes depending on how traumatized the population is. For example, one study had quoted 2% prevalence in the Netherlands versus 6% in a highly traumatized U.S. low income neighborhood. Lifespan development. There is insufficient research on it, but this is what we know. From 5 to 10 years old, you see the first onset of dissociative symptoms, including the emergence of the child's very first alter. DID is most commonly diagnosed around age 30. At the time of diagnosis, the client may have anywhere from 2 to 15 alters or personalities. And without mental health intervention, the diagnosis can be chronic and may persist throughout adulthood. Its etiology or cause is thought of to originate from an interplay between biological, sociological, and environmental factors. So I talked about earlier a genetic predisposition to dissociation can be at play. Psychologically, disorganized or anxious attachment style formulated from inconsistent or abusive caregiving in early childhood could affect the development of healthy coping and emotional regulation. And environmentally, evidence of even a mild history of family dysfunction can lead to the development of DID. And there's a debate on whether it is what's the cause? Is it cognitive, like dissociation based, or is it trauma that causes it, or is it both? So, some protective factors that help mitigate the risk of developing DID even with a history of severe childhood trauma, are secure attachment with the caregiver, a supportive, stable, and nurturing family environment, a having a strong social support outside of the family, and an individual's personal resistance, whether it's like an ingrained personality trait, a cheerful disposition, or an ability to form social connections easily, can prevent the development of maladaptive coping through dissociation. This is my art response. This I might be over dramatizing DID because of all the movies I've seen, but I just imagine what would it be like to pull out your wallet and look at the ID and be like, "That's my face, but who is that? That's not me. That's like not my name." So that was kind of the prompt there. Just kind of exploring identity through like the documents we carry that identify ourselves. And that's it. Thank you very much. Here's my references. And thanks.